Good morning, everybody. My name is Ruth Driscoll, and I'm the Associate Director for Policy and Public Affairs for England at Marie Curie. I'm really delighted to welcome you to the first in this series of Marie Curie seminars, which are exploring challenges and opportunities to improve palliative and end-of-life care for everyone who needs it. I'm especially delighted to welcome our chair, our speakers to this seminar on how 24/7 palliative and end-of-life care can help to improve care for patients and their families, but also to reduce the significant pressures that are facing the health and care system at the current time. So without further ado, it's my pleasure to introduce our chair for this seminar, who is Ian Smith, who is the chair of Surrey Heartlands Integrated Care Board.
Hi, everybody. This is the first in a series of online seminars Marie Curie will be hosting this year to share palliative and end-of-life care challenges and solutions to addressing those that emerge at the local level. Marie Curie is particularly keen to ensure that the conversation around palliative and end-of-life care explores the need for integration and coordination across the whole health and care system to help ease the very severe system pressures we're all facing, and more importantly, improve outcomes for patients and carers. This first seminar will focus on the importance of 24/7 palliative and end-of-life care and the difference it can make both for patients and for the wider system. Around 750,000 out-of-hours emergency department visits are made each year across the UK by people in their last year of life. And the number of visits is highest, of course, in the more deprived areas. These experiences can be highly distressing for patients and their carers, and also very expensive for the system. People wouldn't always need to visit their local A&E department if they could access the high quality and coordinated palliative and end-of-life care they need every day of the week, every day of the year in community settings. So we've got a good lineup of speakers. It's a pretty full agenda. First, we'll hear from Professor Katherine Sleeman, who is the Laing Galazka Chair in Palliative Care at the Cicely Saunders Institute at King's College London. She'll present her research into the challenges people face in accessing services outside of office hours in many parts of the country and the challenges this creates, both for patients and for the system. Marie Curie is very keen that this seminar is grounded in practice with a clear focus on what works. So Katherine will be followed by clinicians who will showcase their innovative work. These include Michelle Knight and Philippa Munk from Cambridgeshire and Peterborough's Integrated Care System Palliative Care Hub, operated by Arthur Rank Hospice in partnership with the East of England Ambulance Service. And Dr. Sarah Holmes from Marie Curie, who will talk about the work of the Reactive Emergency Assessment and Community team based at Bradford Royal Infirmary. We'll then have time for Q&A. Please put your questions into the chat, stating your name and organisation, and we'll get through as many of them as possible. It might not be possible to answer all of the questions today, but we'll follow up after the session. And just so everybody knows, the session is being recorded and will be uploaded to the Marie Curie website. And my request to the presenters is that they stick to time as we've got a very full agenda and we don't want to squeeze Philippa and Michelle too much at the end of the session. So Katherine was joining us a bit late. Katherine, are you online now?
I'm here, yes. Hi.
Yeah, hi, Katherine. So over to you, 15 minutes. I'll give the presenters a prompt with 2 minutes to go just to make sure we stay on time.
Thank you, that'll be helpful. I'm going to share my slides, so please bear with me. I'm hoping you can see my screen.
Yes, we can.
And just turning them into the proper view. Okay, is that in the proper big screen view?
Not yet, Katherine.
Okay.
Yeah, it's good.
Great. So thank you so much for the invitation to speak. I'm really delighted to be here to speak about challenges and gaps in 24/7 palliative and end-of-life care. So as has just been said, I'm a palliative care professor at King's College London, but also a consultant in palliative medicine at King's College Hospital. And I'm the lead for the Marie Curie Better End of Life programme, and actually almost all of the research that I'm going to tell you about is part of that programme. So I was thinking to myself, how can I best succinctly explain why 24/7 palliative and end-of-life care is important? And actually, I think that this extract from the Ambitions Partnership document kind of says everything. So 24/7 access to palliative care is one of the 8 foundations for the Ambitions, which states every person at the end of life should have access to 24/7 services as needed, as a matter of course. The distress of uncontrolled pain and symptoms cannot wait for opening hours. This is a necessary system-wide expectation, and good end-of-life care cannot be achieved without it. All commissioners and providers have to engage in defining how their services will operate to ensure expert responsiveness to needs at any time of day and night. I know clinically, and we also know through speaking to patients and carers through our research, that 24/7 access to palliative care, and in particular out-of-hours palliative and end-of-life care, is a key issue, a key concern. And it's for that reason that we focused on out-of-hours care in our 2022 Better End-of-Life report, which was termed Mind the Gaps. So this report came out in November 2022. You can access it using the QR code on the screen. And for this report, we carried out research. We used 3 different approaches to understand this question of 24/7 or out-of-hours access to palliative care. First of all, we did a big data analysis to look at patterns of out-of-hours acute hospital attendance. Second, we did structured interviews with professionals to understand what services are provided to people out of hours in the community. And third, we carried out workshops with patients and carers living with life-limiting illness to understand more about their experiences and priorities. So this is essentially the content of the talk I'm giving today. First of all, then, to tell you about the big data analysis, we know that if services in the community out of hours aren't rapidly and readily available, then patients may have no choice but to go into the acute setting, even if that is their least preferred place to be. So in part 1, we used big data, routine data, to understand what patterns of acute hospital care are during the last year of life. So on the screen, you can see a figure that shows patterns of emergency department attendance towards the end of life. This data represents every person who died in England in 2020, so just over 570,000 deaths. And there are a couple of key points to take away from this slide. The first point is that rates of emergency department attendance, both out of hours and in hours, are actually relatively low and relatively stable for most of the last year of life. But they escalate as death approaches, so very much higher in the last 2 and the last 1 months of life. The other thing to note is that while both in hours and out of hours ED attendance escalates in those last 1, 2, 3 months of life, actually out of hours ED attendance escalates faster. We were interested in understanding geographical variation in terms of out-of-hours ED attendance. So here, obviously, you can see data for the whole of the UK. There are large variations across the UK in terms of rates of ED attendance by health geography. Some areas had pretty much half the rate of out-of-hours ED attendance at the end of life compared to others. One pattern that we saw was that rates of ED attendance are highest in urban areas. So, for example, if you look at the 5 London ICBs, they have among the highest rates of out-of-hours ED attendance in the country. We were also interested in understanding not just what, but a bit more about who is most affected by this. And one of the questions we were really interested to ask was around deprivation. So what we found when we looked at the deprivation profile of people having ED attendance at the end of life is that there is this absolutely clear deprivation gradient. It's almost a perfect gradient. People who live in the most deprived areas have a higher rate of end-of-life ED attendance compared to those who live in the least deprived areas. And that pattern holds, whether you're a woman or a man, whether you're young or old, we see the same pattern exists. So last, what we wanted to understand was a bit more about why this pattern might exist. Does this directly represent a difference associated with deprivation, or is what we're seeing here the fact, for example, that people living in more deprived areas are more likely to have conditions that change suddenly, requiring emergency department attendance? So the next, this is the last slide in this section, and actually this wasn't published in our report. This is hopefully going to come out quite soon. Is we've explored this question of ED attendance out of hours using an intersectional lens. What the data on this screen shows you is that there are some ethnic groups, so in particular the Bangladeshi, Pakistani and Indian ethnic groups, for whom even if we adjust for age, even if we take into account the geography of where they live, even if we take into account their deprivation profile, and even if we take into account the diagnoses that they have, these groups consistently have a higher rate of emergency department attendance compared to white people. There are other ethnic groups where actually the higher rate of ED attendance is explained by things like geography or deprivation or the conditions that they have. So this question of why these differences exist across different ethnic groups, I think is really critical. It's something that we're only just beginning to describe, let alone to understand, and that's something that we want to take forward next. So the second part of our report used a completely different lens. It tried to understand what out-of-hours palliative and end-of-life care services are provided. And I won't go into detail on the methods, but we did this by carrying out a lot of interviews, 71 structured interviews relating to 60 different areas across the UK that's illustrated in this map. Our interviews were with experienced senior leaders responsible for commissioning or delivering out-of-hours services. And our interview schedule asked about aspects of out-of-hours care that had previously been identified as important to patients and their carers. There's an enormous amount of information in our report relating to these interviews. For the purposes of time, I've just got 4 slides illustrating points that I think are particularly important. So one of the questions we asked was, is there a designated out-of-hours telephone advice line available in your area? Now, this was an important question to ask, not least because I think more than 15 years ago, NICE, the National Institute for Health and Care Excellence, recommended that every area should have a designated palliative care telephone advice line available so that if patients run into problems in the middle of the night, if symptoms escalate, they don't have to wait on a line in line on 111. They don't have to go into the emergency department. We found that about 15 years after NICE made that recommendation, still only a third of areas said that they did provide a designated palliative care telephone advice line. About a quarter said that they didn't, and 42% we've coded as this kind of partial response. And what partial means is it's a sort of yes, but response. Yes, we have a designated palliative care telephone advice line, but it's only available in half of our area. Or, and this was quite common, yes, we've got one, but it's only available to certain groups of people. And as this quote illustrates, very often what we found was that service is only available to people who are on some kind of palliative care list or register, or, for example, are known to the hospice. So it's not available to everyone. What we've done subsequent to publishing our report is taken this data further and developed a practical framework to guide the development of telephone advice lines for people living with advanced illness and their carers. So I really hope that this practical framework will be useful for developing services, and it should be coming out very soon. It's in press in a journal called Palliative Medicine. It was really important to ask a series of questions about medicines because time and time again, if you talk to patients and carers about what's important, access to medicines, access to good symptom control in the middle of the night is what they struggle with and what worries them. If you think about it, if someone develops an acute symptom, an escalating symptom in the middle of the night, say, in order for that symptom to be managed, several things have to happen in sequence. So they may need a new drug prescribed, that new drug will need to be dispensed, and then it will need to be administered. And of course, a break at any of the links in this chain has the same end result, which is that the patient does not have the symptom relief that they need. So we found that there were gaps at each of these links. For example, visits from prescribers were possible in all areas, but actually 65% said that there were challenges with that. We found over half of areas said there were challenges accessing pharmacies overnight, and a third said the same was the case at the weekends. And more than 2/3 of areas said that there were challenges with administering medicines. And what we found throughout our data, actually not just about the medicines data, but globally, was a huge reliance on district nurses to provide out-of-hours palliative and end-of-life care to people with advanced illness, which is fine, except for the fact that there is very often a skeleton staff, and those nurses often find that they can't respond as quickly and as promptly to the concerns of people with life-limiting illness as they would like to. We did also ask some questions about specialist palliative care, and I just illustrate a couple of points in this slide. We asked about whether it was possible to get home visits from a specialist palliative care nurse overnight and at weekends and bank holidays. We found that at weekends and bank holidays, almost 50% of areas said yes, and it's about 25%, about a quarter said no. But the situation is very, very different overnight. 80% of areas said no, it's not possible to have a home visit from a specialist palliative care nurse overnight, and fewer than 1 in 10 said that that is reliably possible. And last in this section, we asked about, can patients and informal carers access equipment out of hours? We found that almost half said yes, and most of the remainder said as a kind of partial response. It was yes, but sometimes there are delays, sometimes things aren't possible in some areas of our patch. What I really wanted to point out on this slide is very strongly through our data whether we were asking about access to equipment or whether it was access to care or care packages, what we heard was that often there are issues and often it becomes the family who plug the gap. And of course, some families are less able to plug gaps than others. So families may not be able to plug gaps because of financial constraints. They may not be able to plug gaps because of physical constraints. And what may well happen then is that those patients have no option but to attend the emergency setting. And I think that reflects back on the data I showed you before, looking at patterns of ED attendance. So the third part, final part, was our workshops with people living with life-limiting illness and their carers to understand their experiences and their priorities. So I just have one slide on this data. The overarching finding when we carried out these workshops with patients and carers was this concept of care as imagined versus care provided. The care that we imagine we are providing from the health professional and service provider side of the equation can look very different when you're on the other side of this equation. Carers and patients told us simply about a lack of out-of-hours support. In fact, some people said it was hard to even get visits in hours. I didn't even try out of hours. They told us that about the emotional and practical labour associated with caregiving. Providing hands-on care isn't just a practical challenge, it actually comes with a huge emotional challenge too. And that is not helped when, for example, you have to search around in the dark to understand who to contact. People spoke about services that were reactive, not proactive, and I think this quote really sums it up. This carer is describing how equipment was arranged in advance for the evening of the day he died, and it was described as all too little, too late. And finally, our patients and carers found the issues of equality and inclusivity and impact on different communities really important. So, for example, one carer said to us, palliative care services are not visible to the Asian community as an option, and they wouldn't know who to contact. And I think, again, that really, it's very interesting to reflect on that, particularly in light of the data I showed, and we're very keen to take that area of research forward, because I think we don't know enough about the issues here and how we might address them. Okay, so summary slide. We found through this work that there are gaps and there's variation in out-of-hours care and services for people living with advanced illness in the community, which may well, almost certainly contributes in some to high out-of-hours ED attendance. We found, quite concerningly, I thought, that nationally recommended services, such as designated palliative care telephone advice lines, are patchy and often non-existent. We found that district nurses and community nurses provide the bulk of out-of-hours care to this patient group, but services are stretched incredibly thinly and they can't always respond as they would want to. And finally, that access to care, access to equipment is highly variable, and it's often families who end up plugging the gaps with associated emotional and financial costs to them. So a final plug for the report, if you're interested in this data, almost everything I presented is in this report. If you would like to get in contact with me, if anything that I've said is of interest, please do so. I'd be delighted to hear from you. And final acknowledgement slide. So the Better End of Life programme is funded by Marie Curie. I have to thank our fantastic patient and public involvement group who have helped us develop this work from the start. And the very long acknowledgement is for all of the trusted research environments through which we access that large data for our large data analysis. Thank you so much for your attention.
Great, thanks, Catherine. And, I think you got the point across. I mean, any visit to an AA department, any department anywhere in the country will show just how pressured those departments are and that the people in them are highly vulnerable people. And we've got to try everything we can to treat them earlier and in a better setting than A&E departments, especially in central cities and hospitals like King's College Hospital, which is close to my heart. Over to Sarah Holmes.
Thank you. My name's Sarah Holmes. I'm a Chief Medical Officer for Marie Curie, but I also practice clinically in our hospice in Bradford. My pronouns are she and her. Catherine's data is fascinating, actually, because it very much resonates with the local data that we had and is the reason for us developing our service, which actually is in ED. If you could go to the next slide, please. So I'll aim to cover all of this in the brief 10 minutes and including some early outcomes data from our service, both evaluation and qualitative studies. We do have more in-depth analysis planned. Next slide, please. So the case for change, Bradford, for those of you who don't know, is a post-industrial city in the north of England with very high levels of socio-economic deprivation and ethnic diversity, and it's the 11th most deprived local authority in England. So to Catherine's data, providing equity and access and provision of palliative care has presented quite a few challenges. Many of the challenges that Catherine highlights play out in Bradford. We have a very ethnically diverse, culturally diverse, socially deprived population. And we knew that we were a national outlier in the number of hospital admissions in that last 3 months of life. So we had the second highest percentage of people in England having 3 or more admissions in the last 3 months of life when a colleague and I came up with this model. We are also very lucky. We have a palliative care single point of access advice line. However, it's one of those issues in that it requires referral from a professional. So anybody thought to be in their last year of life is referred to Gold Line. But if you haven't been identified by a professional, then you're not getting that service. And we knew that there were about 1,000 people in Bradford with palliative care needs that either the Gold Line or our other services weren't reaching and were ending up in the ED department. Next slide, please. So in response to these challenges and having spent years trying to say, well, we need to see people at home first and we need to sort all of that, and not actually making a difference. We realised that we needed to meet patients where they needed it most, so we developed the React service. It's funded as a 3-year programme through End of Life Integrator Impact Bond. So it's a partnership with Social Finance, the Care and Wellbeing Fund, and with support from the National Lottery Community Fund. It's very much a collaborative programme, so it relies on very strong collaboration particularly between Bradford Teaching Hospitals Foundation Trust and Marie Curie Bradford Hospice. But throughout the project, from the very early stages, we've had a steering group with partnership representation from stakeholders across our system, so primary care, district nursing, GPs, hospital trust, finance, CCG, all sorts of people. And we aim to improve outcomes for people presenting with acute, unmet palliative care needs. Next slide, please. So the service, although we bid for money pre-COVID, actually, the service launched in June 2022, and it's has 2 arms to it. So firstly, a consultant-led in-reach model in the emergency department in the hospital team, which picks up patients with palliative care needs, working very closely with our ED colleagues, and where we can, discharging them to the second arm, which is our community React arm, and which is effectively a multidisciplinary, community-led rapid response virtual ward service. The community arm consists of an advanced CNS, specialty doctors, registered nurses, healthcare assistants and physiotherapist. And they aim to assess and provide short-term support to patients in crisis, so they can provide care, equipment, medication, as well as emotional support and advice that patients need at home. And we do that all within a 72-hour period, and then aim to discharge on to existing services. Next slide, please. When the service launched, we've had the sort of challenge of building and designing the service at the same time as delivering it. When we launched it, we focused purely on taking referrals and admitting people from the ED arm of the service and discharging to the virtual ward. So our sort of the indoor was in the emergency department. Next slide, please. From October last year, we expanded the service to support patients in crisis in the community, because of course, as Katherine has highlighted, we want to try and prevent people having to get to ED in the first place. So we're opening to community service referrals in a staggered way, and we've started by opening up to our community specialist palliative care team, which is provided by another NHS trust. Also opening to those patients that are on our hospice waiting list, and just this year, 2024, we've opened it up to our oncology colleagues in the hospital trust as well. So those patients that are seen by acute oncology or going to clinic in a crisis, they are now referring to us. Next slide, please. And over the next 6 months, we plan to expand to open up to primary care, ambulance services and Gold Line, which is that single point of access. Next slide, please. So in terms of the data, there is a lag in the data because one of the KPIs is looking at number of bed days in that last year of life. So looking at the first 16 months of the service, we've supported 521 patients, and over a third of those were not known to palliative care services previously, including not known to Gold Line. If we look at diagnosis, the service is seeing 26% of patients with cancer, which aligns with the ONS data for our population. So the vast majority of patients we see in React have non-malignant disease. And we know that we're seeing more patients from the most deprived deciles compared to our other palliative care services. The ED React team has managed to discharge 63% of the patients they've seen to home, and the majority of those, 80%, have been supported for less than 3 days before being referred on to community services. When we looked at baseline, we knew that patients spent on average 38 days in hospital in their last year of life, so over a month. We've had very encouraging data. So on average now, anybody that's been touched by the React service spends 17 days in hospital in the last year of life. But there is a difference. So patients that are seen by the React service and admitted to hospital, so even if we don't manage to get them home to the community arm, they spend 20 days in hospital in the last year of life, so it's still a reduction from baseline. And if we do support people out to the community arm, they only spend 15 days on average in the last year of life. More importantly, evaluations from patient and staff have been overwhelmingly positive. So we've undertaken a number of qualitative interview studies with patients and staff, and patients report on it really reflecting person-centred approach and increasing their feelings of security and reassurance. Next slide, please. Just a quick patient story. So Peter's a patient with long-standing pulmonary fibrosis, which he's had for years. And over the last 6 months, he's been in and out of hospital 4 times with repeated infections and has spent 20 days in hospital. The React team saw him in ED on his 5th attendance when he'd come up by ambulance with breathlessness, and he'd been started on oxygen, fluids and antibiotics. And the team had a conversation with him and his wife, and through discussion it became very clear that he wanted to be at home. So they discussed those options. He was supported to go home with equipment, oxygen and medications, and there was a plan put in place should this happen again, that he wanted to receive care at home or in the local hospice. The nursing and physio team from React in the community worked with Peter to talk through pacing, breathing technique, rationalise his medications, liaised with the GP and the respiratory team, and he also had advice on benefits. And he stabilised and was discharged to the usual community palliative care services. He enjoyed a further 2 months at home before his condition got worse again in September. And at that point, because the plan was in place, his symptoms were more tricky to manage at home, but he was admitted to the hospice and he had died in the hospice a few days later. So his final months were what he wanted because we'd asked him what he wanted. Next slide, please.
Concluding now, please,
Thanks.
Sarah. And for those with questions, please put them into the chat and we'll answer them later. So
just some quick perspectives from the staff there. That's the staff in the ED team. Some very powerful feedback that the React team make the impossible start to become possible. I think the take-home messages, next slide please, are that we've developed a truly integrated service, and that's been key to it, the collaboration across all the organisations. And the key elements as well are proactively identifying patients and providing a responsive service. There is lots more work to be done to analyse the model and explore its effectiveness and cost effectiveness, but we will be doing that, and we will be publishing data as soon as we can. Thank you.
Very good, thanks, Sarah. And pass on now to Michelle and Philippa.
Hello, thank you. I'm just waiting for Matt to pop the slides up. I am Pip. I'm one of the clinical nurse specialists from the Palliative Care Hub in Cambridgeshire and Peterborough, and Michelle is our matron. Sorry, just waiting for that. Yeah, so our palliative care hub is in collaboration with our ICB and Arthur Rank Hospice, as well as Hearts Urgent Care and the East of England Ambulance Service. Next slide, please. So the Palliative Care Hub is one of those phone lines that Katherine has mentioned. It's a phone line service that's staffed purely by a small team of Band 7 clinical nurse specialists, and we do run 24 hours a day, 7 days a week. So we provide support, advice to patients, families, healthcare professionals, anyone involved in care of someone with a life-limiting illness, so that these patients can receive the optimal care that prioritises their choices and needs. The clinical nurse specialists answer the calls directly via 111 and then selecting option 4 in Cambridgeshire and Peterborough. And this enables patients to talk to us directly, rapidly and responsively without talking to call advisors and having unnecessary questions asked or talking to any junior staff. We set it up in 2020, we went live in April 2021, and we managed to move to 24/7 in April 2022. A key driver was the national requirements for all ICBs to provide 24/7 specialist palliative care via a phone line. And previously we had a very similar system in place where patients would have to ring the hospice and they would have to be known to the hospice. And I think it sounds like it's quite a standard way of doing things in a lot of areas. This meant that advice was limited and support was only offered to a small number of patients. It's important to us to note that patients do not need to be known by any hospice services, any palliative care services, don't need to know of any of those, don't need to know of any numbers. Anyone with a life-limiting illness can access our service just through 111. And being routed through 111 means the number is easier access to all, there's no call charge, there's no number to remember. And to achieve this, we work in partnership and collaboration with our integrated care system colleagues, especially with Hearts Urgent Care, the out-of-hours service, who provide access to 111 and their telephony platform, and the ambulance service, who developed an integrated pathway and a decision-making model that we work together with. Next slide, please. So since starting, we've received 6,688 calls into the hub, and I think that's in 30 months. As you can see, over half of those calls come from relatives and carers, which would have previously been directed to the ambulance service, to A&E and to out-of-hours GP services. We're reducing delays in provision of care as we're supporting our busy colleagues by completing referrals, liaising with other teams on behalf of the patient, and we're easing capacity pressure on other primary care, A&E and ambulance services, reducing wait time for the callers needing our help by enabling that direct access to our specialist care and advice, rather than waiting for callbacks, waiting until office hours, or not knowing which service to access, who to call. Next slide, please. One of our main aims was to reach areas of deprivation, and particularly Peterborough and Fenland, Wisbech, are our most economically and socially deprived areas. So the fact that we're actually receiving proportionally more calls from these areas is especially important, as there is an inequity of service provision across the county. It indicates that we are reaching the patients that may have found it harder to previously access support and care. And from the data available, we know that patients from geographically isolated, economically and socially deprived areas are more likely to end up in hospital and get stranded in hospital and die in hospital, even if it's not their preferred place of death. Almost 50% of the people we have helped were in these deprived areas, and we're now supporting them to be cared for and die in their preferred place, which is generally home. And this obviously not only improves quality of life for the patients and their loved ones, but it reduces the pressures on the hospitals. Another innovative part of this service is our ability to reach out to patients with non-malignant disease. So CQC 2016 highlighted people with non-cancer diagnosis tend to have less access to support at the end of their life, and therefore may have poor experience in the last phase of life. And we have successfully increased calls from 21% of calls received being from patients with non-malignant disease when we started to 32% of calls being from those patients now. Next slide, please. So you can see the primary reason for calling are pain symptom management and medication issues. However, we often get multiple complex reasons for calling that include physical symptoms, and then it ends up highlighting a lot of social and emotional issues as well that we can help with. So one of the main reasons for crisis admission to hospital for palliative patients is uncontrolled pain. Previously, callers would have had to talk to an out-of-hours GP or a nurse that was not a specialist in palliative care. And the ability to discuss directly with one of the specialist team means that patients are supported to stay at home comfortably with appropriate symptom management and reducing the likelihood of that symptom crisis. In Cambridgeshire and Peterborough, we use RESPECT forms, which stands for Recommended Summary Plan for Emergency Care and Treatment. And the RESPECT form process creates a summary of personalised recommendation for a person's clinical care in a future emergency, in which they do not have capacity to make or express choices. We are experienced and skilled in discussing advanced care planning and supporting the RESPECT process if this isn't already in place. So we're actually able to have those conversations over the phone as well. Next slide, please. And I think this should be just a very brief video from one of our users. Yeah.
So I'm just going to unshare and just put some sound on it. So just bear with, yeah.
Might need to move on, Matthew, if you're having trouble.
We can leave that one. It was just.
Yeah, I think we better move on.
Could we go to slide 7 then, please?
Michelle have some time, yeah.
So, as we've shown, we are improving access to specialist care across the county to help provide more equitable care. Through our collaborative working, availability for support even out of hours, and our specialist knowledge and skill sets, we've been able to avoid 410 admissions to hospital since we started. These have generally been in collaboration with EAST, the ambulance service, using a shared decision-making tool. And we've been able to liaise effectively to ensure that appropriate support and symptom management is in place for these patients, have difficult conversations with confidence that help patients and families understand what's happening and ensure they feel safe and supported in their preferred place of care or death. We've also reduced the number of calls going to out-of-hours GPs by approximately 62%. So this means that only the really necessary calls get transferred to the GPs for actions we are currently unable to do, like home visits or prescribing, although we can liaise with the GPs for prescriptions, and we do. This reduces the burden on out-of-hours services and increases time and capacity for other patients on ensuring that palliative patients receive their optimal care and support. Patients, families and other healthcare professionals only need to make one call into the hub and we can do the rest. So we collaborate with, refer to and coordinate other services, and this liberates the healthcare professionals to focus on the patient or to move on to their next patient. And this means that family can be family rather than spending time phoning multiple services, going around all these different phone calls. So our data shows we've received these 6,688 calls, but have generated a further 8,702. As well as System 1 tasks and emails that haven't been captured in that data, which indicates the amount of liaising we are carrying out on behalf of these people. And aside from reducing burdens and increasing financial efficiencies, we're improving patient and healthcare professional experience. So next slide, please. These are our numbers. So just to very briefly touch on it, using our data from our System 1 and national NHS cost data, we've worked out the efficiency we've created for the local system, which is nearly £1 million since we started, which is brilliant. But our positive impact on patients and other services is very far-reaching, and it's not quite as quantifiable as that. Next slide, please. So this is just a little word map of our frequently received feedback. Next slide, please. So I'm going to very briefly touch on this because it's not as important, but we've got lots of plans to sort of expand the service and improve based on the data that we've already captured since we've been up and running, that would further improve access and support for those patients. Next slide, please. And these are our contact details. Feel free to email us with any questions. I will actually put my correct email address in the chat because I've added a dot where there shouldn't be one. So, but yeah, any questions or anything else, we'd really welcome anything. Thank you.
Good, thanks very much. We've actually got quite a few questions, and those we can't answer, I think Ruth and team will follow up. Ruth, do you want to read out some of the questions that we can get to?
Yeah, absolutely. So there's been a couple of practical questions in the chat for Sarah Holmes about the React service. So the first of those is, please can you advise what times the service operates in ED? And that was from Zoe in Kent and Medway. And the second question was, how many staff are there in your team in ED at any one time? And then there was a third question of, how do you manage those who are not known to services as palliative? So one of the challenges that Kathy was describing in Hertfordshire is ensuring qualitative and supportive advanced care planning conversations. So if the React team or the hubs pick a person up, how do you identify a lead? We keep saying that this is everybody's business, but in some ways it feels that this doesn't give ownership. So that last question was perhaps for both of you, but Sarah, do you want to go with the first two practical ones there?
Yes, thank you. So times in ED has been something that we weren't sure about as we started the model. We are funded for 4 hours of consultant time in ED, and we didn't know what time that was best to put it in. It's 7 days a week. In reality, practically what happens is it's sort of blended over the working hours of the day. So the consultant attends the sort of morning handover at 8 o'clock and sees if there's anybody around that they can pick up. If not, they pop back down. So they work both in the hospital palliative care team as well as the ED department. In terms of staff in ED, it is the consultant. One of the really positive things about the service is that on the back of the service starting, we've now actually also got a clinical fellow in ED. So a clinical fellow does 50% time in emergency medicine and 50% of their time in palliative medicine in the React service, which I think if we'd tried to sell to them 4 years ago, they'd have said, there's no way you need palliative medicine and ED medicine. So that's been really positive. Our community arm also works slightly flexibly. So the more senior advanced clinical nurse specialist will go into ED if there's more work in ED than there is in the community arm at the time. So she'll flex across the system. In terms of managing patients who weren't previously known as palliative, that's obviously been a key part of the service. So actually identifying those patients, and it's been absolutely crucial that then those patients have an advanced care plan done, so or offered at least. So there's a discussion, and I think it's changed our thinking about advanced care planning in emergency acute situations, actually, that it needs to be done as a sort of offered as a treatment in the same way that you would offer any other treatment, because it is the treatment that prevents people coming back. We have very clear discharge processes at the end of that 72 hours, so that we are very clear that they are identified as palliative, they are referred to our Gold Line single point of access, they're put on the GSF register, and they are handed over to whichever is the appropriate service. They may not have ongoing specialist needs, in which case they'll be handed over to primary primary care services, but we do identify a clear service to pass them on to.
Thanks, Sarah. Would Philippa and Michelle like to come back on this question as well about advanced care planning? If the hub picks a person up, how do you identify a lead person and deal with that challenge of saying it's everyone's business, but who's got ownership of that?
So that's, yeah, I mean, it's quite an interesting one. Obviously, because our service relies on patients accessing us first, they've kind of already identified themselves as palliative, or someone very close to them has. Quite often they will have advanced care planning in place, not always, but because we are a response service like 111, the primary care would still be for the GP, unless, you know, we would always send an email to the GP involved and update them, and then update any other teams that are involved, but it would still be the GP that was the primary clinician looking after that person.
Thanks, Philippa. So we have another question in the chat. The small number of out-of-area calls that you mentioned, is this from people who cannot access a similar service in their own area?
Yes. So the way 111 works on masts, and actually we take, so Cambridgeshire and Peterborough, we take, if you've got a Cambridgeshire and Peterborough postcode, but some of the borders, you might get pinged to a Cambridge and Peterborough mast, even if you're not in our area. So sometimes they just get through to us accidentally based on location. You won't be offered 111 option 4, which is our number, unless you are in that catchment area. So it just happens to be the borderlands. Sometimes it pings the wrong way. It's, yeah, a logistical thing.
So wouldn't it be great if we had one in every area? Okay, we've got another question, Ian, in the chat. So following on from Kathy's question, do you have access to all records? So this is from Mary, and she's saying we do not have access to all the records, and there are concerns about replication of services and also safety of advice without being able to see all the input. And there's another person, Howard, is asking a similar question. A big issue. Is this a vital component of both these successful initiatives?
We do.
Sorry, Sarah, before you jump in on that one, I've just spotted a third question, similar topic. So a question for Philippa, what IT and patient information does the hub have access to when working with patients and their families? Are all the places using the same IT software? Now we're really getting down to it, aren't we? Sorry, Sarah, back to you.
So in Bradford, we're really lucky in that most services use System 1. So we do have that shared record element. The irony is that the hospital trust adopted a different EPR. So that's the only part of the system that uses a different record. So we do have to kind of duplicate our records in the hospital system and in System 1, but across all the community services and palliative care services we have System 1, which is key to the success, I think, seeing that.
Yeah, and we're very similar. So I think we've got 109 surgeries across the county, and 101 of them use System 1. So we've got a few outliers, but we can access basic notes from the spine. Our hospitals do use different systems as well, but the majority, we don't get calls from patients in hospital. Basically, they're all community. So yes, and again, having access to System 1 notes, especially because we're not physically seeing those patients, having access to the System 1 notes and the history is essential for our service.
From our point of view, priority of actually speed of upload of discharge summaries is really important. So something else I think as we're going along, we're actually finding where the problems are, and actually there we can actually input and actually improve even further.
Thanks. So we've got one more on information sharing. How do you record and capture information from those who contact the hub, please? Just thinking in terms of sharing of information or GDPR and notes being shared in real time. And then conscious of time, I'll just put another couple of questions at you. And let's see when Ian does his tight chairing. If you give medication advice overnight, are you still reliant on district nursing services to administer that? And is your respect process electronic as well? I think these are for Michelle and Philippa.
Could you remind me of the first one? Sorry, I'm keeping them in my head and I forgot the first one.
Yeah, sure. So the first one was, how do you record and capture information from those who contact your hub? Just thinking in terms of sharing information, stroke GDPR, and notes being shared in real time.
Yeah, so we have on system 1, we've got consent process when we first start, which you ask for consent to share in and share out. If someone consents, that means we can see their whole history. We then put an entry on system 1 and that gets shared out to anyone else who has access to system 1. And we then send an out of hours notification to any service that patient is registered to. So district nurses, GP, anyone involved in their care will get an out of hours notification to say that patient has contacted the palliative care hub. So as far as district nurses are concerned, yes, we are reliant on district nurses to administer that medication. And we are very aware that that is a service that is quite depleted at the moment. So it can be quite tricky for them because we're asking them to do quite a lot, but they're brilliant locally and so try and get out within an hour to administer those medications. And finally, sorry, go on.
Sorry, can I just interrupt with the district nurse bit? But actually, the girls actually provide a point of call for the district nurses, so they actually often give them reassurance that actually they are appropriately administering the right meds at the right time, and particularly when we've got a lot of junior district nurses out there at the moment. So, and I'll go with the respect. Yes, the respect has just moved online. So actually we can access our respect forms through system 1 and actually it then becomes a digital and it can be seen straight away in the communications page for actually professionals.
Thanks, Michelle. Ian, do we have time for one more question?
I think we better draw it to a close, actually, Ruth.
Sure.
We're going to follow up with the questions just to make sure that we finish on time. So thank you for the speakers and for everybody attending. It was a very good turnout. As I said at the start, this is the first in a series of online seminars that Marie Curie will be hosting this year. The next one's on the topic of access to palliative medicines in community settings, and that'll take place in May. So after this call, Marie Curie will share the slides. There'll be a policy briefing on the importance of 24/7 PEOLC, palliative and end-of-life care in the community. There's also a feedback form to help refine the format for future seminars. Ruth, do you want to give a final thank you and goodbye?
Yeah, enormous thanks to you, Ian, and to all of our brilliant speakers on the panel, Katherine, Philippa, Michelle and Sarah. And thank you so much to all of you for joining us. This is really important work and we need to do it in partnership and in an integrated way. And good luck as you go forth and conquer the system pressures, but also the challenge of making sure everyone has the best possible experience at the end of life. Thanks for giving us an hour of your time on this today.
Thanks, everybody. Bye now.
Thank you. Bye-bye.